We have the last speaker, Dr. Kasturi Bhattacharya. Well, she's the director of Shankar Mahadev in Guwahati, and she'll be speaking on advances in management of orbital and optic canal fracture.
So, Sanjay has decided not to introduce anybody because everybody is big person.
Yeah.
What he says.
All the speakers are big, sir.
Thank you very much, respected chairpersons, my seniors, my colleagues, and my juniors. At the outset, I would like to thank Oculoplastics Association, OTSI, for having me in this forum. It's really an honor for me. So I'll be speaking on advances in the management of the orbital and optic canal fracture. When we start with the orbital fracture, it can be in a very simple way classified as either a blow-in fracture or a blowout fracture. Or it becomes more complicated when it becomes a pure fracture where the rim is intact and the walls are fractured, or impure fracture where you see the fracture of the rims and also the wall. Many times the fractures are still further complicated when it is associated with a Z fracture, that is a pyramidal fracture affecting the zygoma, or a fracture which is the Leaford fracture 2 and 3 which involves the orbit, or associated with the NOE fracture which involves the nose, the ethmoid and the orbit. More complicated when it affects the orbital apex, because in the orbital apex we have a very important structure, the optic canal and the superior orbital fissure, where all the important structures, it passes to the canal, especially the ophthalmic artery and the optic nerve, and the major nerve to the orbit passes to the superior orbital fissure. So any injury can lead to a direct or indirect traumatic optic neuropathy. And if we go beyond this, we see more complicated fractures where the whole of the globe is subluxated, either cranially through the frontal sinus, or it may get subluxated in one of the sinuses, either to the ethmoid sinus or to the maxillary sinuses. So a fracture can be a very simple fracture involving the rim or the wall, and it can be as big a fracture like this, where you can see the whole of the globe gets subluxated intracranially or into the one of the sinus. And one of the major advances is the navigation system, because this gives us a roadmap to the surgery and we know the endpoint of the surgery. Here the data is preloaded into the computer, and this gives us the real-time updates, and this data are in the form of the CT, MRI or MRA, and the real-time updates gives us the intraoperative localization and the endpoint of the surgery. The software equips us with the tools for differential color coding, precise marking, and mapping of the site of the pathology. As you can see here, that both MRI and MRA can be incorporated. One of the biggest use of this navigation system is unilateral fracture, where you can do a segmentation and a mirroring. What is mirroring is that we merge the normal over the abnormal, and this gives us a perfect calculation is how big a fracture, how much amount of reconstruction we do, and how we design the patient-specific implant. I've been using it extensively for the preoperative planning in the pipeline for the customer's reconstruction of the orbital fracture, where both the horizontal and the vertical buttresses are being involved, and in also very complicated fracture, which I have already mentioned, where you see the fracture of the wall and you see the fracture of the rim. So these are some of the patients where you can see where we use the navigation system, and this is what is known as mirroring, where you have the normal being superimposed on the abnormal, and then you can know how much amount of inophthalmos is there, how much amount of socket expansion has been there, and once you do the registration and go ahead with the surgical procedure, you can do a very customized reconstruction in the way, or you can also design and customize the implant as you want it in order to give a adequate correction. So this is some of the patients where you can see a very good adequate correction, both in terms of the function. As you can see, this is the titanium implant that has been placed, also in terms of cosmesis following some very major road traffic accident. A most serious problem is that when you have an optic canal fracture, this is very sad because these are usually following road traffic accident, and these patients are usually in the very productive age. They are 22 to 25, they ride the motorbike without any helmet, and they have a temporal slight trivial injury but which leads to the total loss of vision. So it is very challenging to do the decompression of such situation, because we know that optic canal is in a very important, is a very deep inside the orbit, approximately 44 to 48 millimeter down into the orbit. So what with this navigation, you can do a very minimally invasive transconjunctival approach, where you make an incision and go 24 millimeter and reach the anterior ethmoidal blood vessel. So here I'll put my navigation stylet and I'll see whether I have reached a perfect plane. And once I go further, I reach the posterior ethmoidal blood vessel. I do not cauterize here because I know the optic canal is nearby. And this is my stylet showing I am still in the posterior ethmoid, and it is guiding me that I need to go further beyond till I see this optic canal with the optic nerve having the annulus of the zinc, the Y-shaped structure. So you need to reach this structure, and with so much of fat and other structures in the orbit, without a navigation system, it is not safe to do a surgery in this system. This patient had a hematoma, so following the exposure of the optic nerve or through in the optic canal through an orbital approach, I have used a MVR to release the blood, as you can see here. So these are some of the advantage of using a navigation system, and it tells you the endpoint of the surgery. So this is, you see, the stylet that I'm using. Every time the stylet is entering the sphenoid sinus, that means my surgery is not complete. I have not decompressed the optic canal as correctly, and I need to go for further decompression. So this is at least telling me that my surgery has not yet been completed. So I further go ahead and decompress the superior and the superior medial wall of the optic canal. We should be very careful here because inferior lateral you have the opticocarotid recess with the internal carotid artery. So now my navigation system, you can see from the proximal to the distal end of the canal, the system, the stylet, the tracker is going so well, and you know that you are in the correct plane, and this is the endpoint of the surgery. So another advances is the 3D printing, and this 3D printing has really revolutionized the socket reconstruction that we do, and this really gives us a pre-operative planning that how to go ahead with a very major fracture, which I have already mentioned, where you have first the 2D images, and these 2D images are then converted into the 3D images, and following the conversion of these 2D images to the 3D, we export into the surface tessellation format, and we get the 3D printing. These are the different 3D printings that we use for different types of the surgery involving orbit and the socket, especially in major fracture like this, where you have everything is fractured because of a road traffic accident, and you do a mirroring and the 3D printing, and then you see the results, because when there is a too big a fracture, the whole of this orbit becomes rectangular, and this post-operatively where you see the rectangular orbit comes back to the oval pyramidal structure along with the correction of the inophthalmus. So this is the patient you can see in the different view, and a beautiful correction of the inophthalmus, and these are some other patients. I think I'll just finish it. I can take. And this here you can see, this is another girl having a very major fracture. This is an NOE fracture. This is really challenging to us because, you know, when they have a fracture, they'll go to a neurosurgical specialty, then to a maxillofacial, and lastly comes to us with too much of adhesion. So these are little challenging for us, and you can see, but still, if you have a technology and if you know the technique, it really helps you to give a very adequate correction. This is a very sad, he is an engineer by profession, he had a road traffic accident, and you can see the whole of the zygoma has come out. So here also we had to do a 3D printing, and along with the 3D printing, you get the adequate correction, and also I had done a traumatic optic neuropathy decompression where I could salvage the vision of the patient and also correct the inophthalmus. Lastly, I will end by showing this, this slide because it's a very sad, like this gentleman, he is from the medical profession. He just came out from his house and he had hit a lamppost, and after hitting the lamppost, this is how he comes to our unit, and this is a total luxation bulbi. But the saddest thing is that he has come to an ophthalmologist, and I was wondering, being an ophthalmologist, how do I manage with so much of CSF leak? So here the interdisciplinary action in an interdisciplinary friend should help us, especially the neurosurgeon, where we had to call the neurosurgeon, and along with his help, we could go ahead with the surgery. So this is so, it's so sad, like he just came out from the house, he was not wearing a helmet, and just he had hit the lamppost, and just got recently married, and have a 2-month-old child. So it was very traumatizing for me also. But we had done the best. Immediately we had taken him for the surgery with arranging all the ICU facility and also with the neurosurgical setup. And then we have done the repair where both the neurosurgeon and also the ophthalmologist working together. And you can see that the craniectomy has been done, and then we had to do a NOE repair. We had to replace everything what is there. This is the NOE repair with the titanium plate, and titanium screw has been given. Ultimately, though we could, manage the situation, but this is the end stage of the patient. So other advances I would like to just briefly mention is a robotic surgery. These are some real technological advances, especially in hard to reach area, and the augmented reality, which is much better than the virtual reality which we use for training the students. Augmented reality, you have a 3D, picture, CT, MRI or MRI on the surgical field. So it is very safe, especially when you do something near the apex where you have the ophthalmic artery and also the optic nerve. And in fact, in one of my patients, you will see very interestingly, I was planning to do the optic canal decompression on the right side. When I had done an MRA and when I have superimposed, in the left side, within the optic canal, there was an internal carotid artery. Touch it. If I would have touched the left side, then the patient would have bled to death on the table. So this sometimes it is very important, especially for the safety of the patient. You have to take the help of the technology. Thank you very much for your patient hearing.
Thank you, Dr. Kasturi. Questions from the audience? Well, I think it's amazing to always see your videos, and just for the knowledge sake, this guided image thing, how expensive would it be for
a institution? It is cheaper than your flex machine, the lens machine, much cheaper, and it comes to now I think this much should use 50 L or something like that for an institution. But when I was showing the 3D print, like someone was telling me, "Madam, you're using something so costly." But sir, like when we do a phaco, we charge approximately, with the best of the IOL, we charge 20,000. But CD printing is only 12,000. So it is important that sometimes we need to know how to reach and how to repair, and we have to take the technology.
Maybe. Well, thank you very much, Dr. Kasturi.
This is something very interesting, how I started. Like I remember 2017, an engineer came to me and he was having a traumatic optic neuropathy. This is my learning experience. When I looked to the CT films he had done elsewhere, there was no bony segment. But then I have decided, when I read, I had seen that all the CT slices were at 1.5 millimeter. Then I asked one of my radiologists that can we have smaller slices? Then he mentioned I can have it at 0.6. And believe me, when I took at 0.6, I could see a fragment impinging on the optic nerve. So then I thought that I should do something for him because he was totally helpless. I went to the Guwahati Medical College Anatomy Department and had done lots of cataract dissection. That how do I reach the canal? Because if you go through the International Optic Nerve Trauma study, the consensus is that you do something, you can hope the vision will improve, or you don't do also, vision may or may not improve. So till today there is no guidelines. So when I started doing surgery, then I thought that when I was doing the cataract dissection, I realized the internal carotid artery lies just infralateral to the canal. And then I asked my intervention radiologist that if I touch, what will happen? Then they told he will bleed to death. So I was very scared. Then I approached my management that I need a system who will help me. And believe me, that patient, next day from PL negative, he became PL positive. Next day. And slowly his vision improved to finger counting. He can see patient moving around. It's not that he has got 6's vision, but some amount of vision. Slowly, I have started doing more cases. There was also another medical professional. Then he came to me on 21st day. And he was also NPL, not MPL. He had finger counting 3 meters. And today his vision is 612. But I had done approximately 80, but everyone did not improve. That is also true. Out of them, approximately 40-45 have improved only, like from PL negative to PL positive hand movement, or someone could see. There's one patient operated after 3 months. He also improved. So now we are just taking out all the data and find out who are the patients, why they're improving and why some are not improving.
Thank you, Dr. Kasturi.